great to be here for the first Vascular News Live ever. And I'm joined by both Vascular News editors that focus on peripheral arterial disease and critical limb-threatening ischemia. In the studio, we have Professor Rob Morgan from St. George's and also Eric Secemsky, Professor Secemsky from Harvard. So from both sides, representing Vascular News North America and also Vascular News Europe. This is a focus on peripheral arterial disease, but it's also a focus on Charing Cross because the next issue of Vascular News is the CX Special Edition. Over to Rob, because you have two hats. You're not only a Vascular News editor, you're also on the CX Executive Board.
Thanks, Stephen. It's a great pleasure to be here. We have a galaxy of stars in this webinar, and we're going to introduce them in turn. We have Brian DeRubertis from New York. We have Marianne Brodmann from Graz, Thomas Zeller from Bad Krozingen. We have Naseer Ahmad from Manchester, and last but not least is Eric Secemsky from Boston. Given that we have the Charing Cross Symposium just round the corner, I just thought it would be useful to start by asking each of our speakers the one or two top highlights that they're looking forward to in this year's Charing Cross Symposium. So I'd like to ask Brian, first of all, what he's looking forward to seeing you at the Charing Cross meeting.
Yeah, I'd love to answer that. I think that it's hard to pin it down, quite honestly, to just one thing. What I will say is that the past couple of years, there's been so many great advances, both in the below knee space and above knee space, especially as it pertains to drug elution, various types of anti-restenotic meds that are being evaluated in clinical trials. So I think the program just has a really good mix of both lower extremity below knee disease, FEMPOP, interventional techniques and technologies, as well as the aortic program. So I'd be hard pressed to pin it down to one area that I'm most interested in.
Thanks, Brian. I'm going to ask Marianne next.
Yeah, the same. I have the same answer as Brian. It's this mixture of different kind of topics. This is what is always amazing me. And what I really like, you have also the venous and DVT treatment line, so you can also not only get the new things from the arterial, but also from venous and also from the aortic space. And I think this makes Charing Cross really unique, to be honest. And I like that format very, very much.
Thanks, Marianne. I'm going to ask Thomas next, and of course the choices open to you are narrowing given these previous two speakers.
Well, basically, I'm pretty much looking for another edition of intense, controversial discussion. That's, I would say, the trademark of Charing Cross, regardless which topic will be presented by, as usual, rapid fire presentations. 5 minutes is not that long, so it will be very focused presentations followed by hopefully fruitful discussions. That's what I'm looking for.
Thank you, Thomas. Next to Naz, who's heavily involved in the CLTI program. Naz, your top picks for Charing Cross?
I guess two things. I mean, Thomas kind of stole my thunder there. For me, it's always the debate. It's a short presentations followed by the debate where you can get really under the skin of certain issues. The other thing I personally also enjoy are the workshops and meeting the trainees of the current time and future consultants. And I know we've got a trauma workshop as well as a vascular anastomosis workshop as well. So seeing the surgeons and the radiologists of tomorrow, I really enjoy those discussions as well.
Thanks, Naz. And finally, Eric, what are you looking forward to?
So I'll be more specific. I think the PAD program in particular on day one of Charing Cross stands out to me. And I think we've seen a lot of evolution in the data for Limus DCBs with the Sirona trial now. We're going to have some podium first data from some other data sets in Europe on the Limus DCBs in comparison to paclitaxel. So we're finally going to have a really well-informed conversation on where this field's going in terms of the right anti-proliferative agent. And then that precedes the really nice debate on bioabsorbable scaffolds. And these are the two hottest topics in the US and outside the US right now. And so to have it all covered in day one of the PAD program and have some real experts and some new data will be quite exciting for me to attend and participate in.
Thanks, Eric. And we're going to have a chat about the bioresorbables in a moment. But I should ask Stephen what, in fact, Stephen's looking forward to at this year's Charing Cross meeting.
I'm very much my father's son. When he started this, he's far younger than I am today. And one of the influences was precisely what you discussed as a group. For him, the discussion between a world-class faculty and the audience that he saw as expert was very important. But above all, the debate. And I was so taken with the debates that I saw at Charing Cross that I eventually became a student debater and a politician, where debate is really part and parcel of being successful. So being able to win your argument. So I'm looking forward to the great debates.
Thanks, Stephen. One of my personal favorites is one of the sessions on the last day when you have the key industry spokesman come into sort of it's like a dragon's den sort of thing. And I'm looking forward to that. So that's, again, I'm looking forward to that this year.
Great.
Okay, so that sort of sets the scene for the discussion. We have a few focused topics which we're going to run through in the next 25 minutes or so. The first one we're going to talk on is BTK drug-resorbable stents. So if you don't mind, Brian, if you wouldn't mind kicking off with that, please.
Sure. I think it's a great place to start. We will have a fair amount of discussion about this at the meeting, of course, coming up. And I think it's a great place to start because it's one of the several areas in PAD in particular and CLTI that is most intriguing to everyone and maybe on the top of everyone's mind. I often comment on the fact that in the last decade or so, there have been a number of failed trials below the knee. And there was a general sense of malaise, I think, in the last few years about the likelihood of a successful trial below the knee. And everyone felt we really needed a win for the space. And that's where the LIFE-BTK trial luckily came through. As of course, as you know, this is a multi-center randomized controlled trial of 261 patients between is the Esprit bioresorbable scaffold and PTA. And the real benefit of these devices, of course, is it hits both the mechanical issues that we deal with that threaten patency, residual plaque, recoil, et cetera, as well as the biologic issues of restenosis. And with this ultimately successful trial, which showed a very significant difference between these two arms, it really led to renewed enthusiasm for the below knee space in general, and certainly bioresorbable. Of course, it sort of ushered in more investment and more excitement about bioresorbables and below knee disease in general, and the belief that we could really tackle and challenge and be successful at challenging below knee disease. And the exciting thing is that it doesn't just end with LIFE-BTK and the Esprit scaffold, which is now available in most geographies, but it also we also have a number of other devices coming down the pipeline. So of course, there's the Riva Medical with the Motive scaffold and the Motive trial. This is an interesting device in that it's more visible because of the tyrocore structure of the device. You can really see the scaffold, and that's already close to enrollment, if not actually might have been completed enrollment at this point. Aaron Armstrong and Andre Schmidt, of course, are leading that. And then R3 Vascular is coming down the pipeline with their own multi-center randomized controlled IDE type trial with the Magnitude trial. So this also is another device which has very high molecular weight. That brings with it some different properties that the Esprit scaffold perhaps doesn't. So, of course, Dr. Secemsky, Dr. Brodmann, Dr. Barco are all helping to head that trial, so they can say more about that. But I think that this is a very exciting time for these type of devices because they were very much needed, and we definitely needed at least one useful tool, even though there are certainly other tools that we're going to need as adjuncts to these devices. But I think these are really exciting devices, and it's an exciting time for below knee disease in general.
Thanks, Brian. I think many people, including myself, were generally surprised that bioresorbables, which had held such promise for many years, finally came through with the results that we saw in the LIFE-BTK trial. If I may ask Thomas where he thinks that we may be in sort of 5 to 7 years with bioresorbables, whether they be the the great solution for BTK disease, or whether it's just another treatment that we need to evolve properly?
Well, I'm not yet fully convinced that it will become the future of BTK treatment to implant scaffolds. What we learned in the past from any kind of stents, regardless whether these are coronary stents, meaning drug-eluting stents, whether these are self-expandable, low-profile nitinol stents, self-expanding drug-eluting stents, like in the Zeller study. In longer lesions, so far, no scaffold-based treatment did prove efficacy. Longer lesion, I mean longer than 10 centimeters. I would be more than happy if this would be the solution in the future. But what we learned is basically that all these scaffolds are more or less going down in these longer lesions within latest 12 months. And bioabsorbables remain at least 12 months, so they do not disappear before that. Therefore, even if it's exciting to see the outcome of this particular trial, live BTK, it has to be shown that it's effective also in longer lesions.
Thank you, Thomas. Eric, do you think the Elite BTK stent is going to be as good as, better, or we don't know, compared with
the... Great. And I think, again, I share Brian's enthusiasm, and I appreciate Thomas's caution in terms of how this space kind of plays out. I do think there will be a role for primarily scaffolding proximal tibial vessels, but maybe it's only limited lengths, to Thomas's comment, and you need adjunctive therapies like DCBs for the more distal vessels. And, again, I think many of us in the US, not as much myself, but others still believe in coronary stents. And so we have to think more about what's the right long-term play for our patients. But, the nice part about the newer technology, and for R3 Vascular having the magnitude stent, is the evolution of these devices will change kind of how we think about incorporating them. These newer scaffolds are sub-100 micron scaffolds, but maintain these very low profile strut thickness through larger diameters and longer lengths. So we're already seeing 78 millimeter stents. We'll see 98 millimeter stents, and still preserving sub-100 micron strut thickness. And I think that will at least facilitate, hopefully, some of the challenges where you can get scaffold thrombosis or restenosis when you have more crowding of the lumen. But I do think also the promise of this technology will evolve from the BTK space to above. You can imagine a bioabsorbable scaffold having more of a play in somewhere like a popliteal artery, or even a common femoral artery, or along even SFA, where you really don't want something permanent there, or something that can fracture or cause trouble. And so, I think that this is a first step in terms of how we use this technology, but I can see us evolving, and in future Charing Cross is debating other locations where these type of technologies might have a more suitable role.
Thanks, Eric. Marianne, any final thoughts on the bioresorbables?
A lot of things has already been said, and I think if you have bioresorbable scaffolds working, we need then to find an algorithm when to use it. Is it primary if you have longer lengths from the vascular, or will we use it as a bailout when we have a efficient TCP for below the knee working? So I think there will be a place, but we need to define what this place will be.
Thank you. I think these are really exciting times for the BTK space, including the bioresorbables. I think we must move on to the next topic. We're going to move on to Limus trials, and Marianne has kindly agreed to talk about these.
Yeah, Limus trials. We have several Limus trials right now ongoing. For sure, there was also this paclitaxel issue in the past with this safety issue of paclitaxel, which has been cleared in the meantime. So therefore, this Limus-coded technology for sure made a step forward to step in for paclitaxel-coded devices. In the above-the-knee space, in my opinion, we have enough data for paclitaxel-coded devices. So therefore, in my opinion, in the above-the-knee space, it's not so relevant to evaluate limus-coated devices. In the below-the-knee space, where we do not have a really big RCT for paclitaxel-coated devices, we have a lot of failed RCTs there. I think there it might be a space to evaluate this kind of technology. The issue with limus is, and we all know that, the difficulty to produce a sufficient and efficient balloon to bring the drug from the balloon into the vessel wall. That needs a lot of technical things to produce such a device. Right now, there are below-the-knee studies ongoing. The biggest one is the solution below-the-knee study. We have good data from small trials like the swing study. Brian DeRubertis was the PI of this small study from the Sundance balloon. And I think we need to, it's too early to speak about really what the value of this technology will be in the PAD space, because we do not have this amount of data so far. We need to wait.
Can I just comment on that? Because just listening to both discussions, it's almost as though we're introducing new technology and we're trying to work out where it's going to have applicability once it's been introduced. Certainly, I'm a bit confused about the sirolimus because the sequencing seems to be different from the coronaries. If I remember right, sirolimus came first as a drug-eluting stent. Then you had paclitaxel. So is the sirolimus balloon being introduced because of quasi-safety concerns, or is it being introduced because you think it may work where paclitaxel failed, which is below the knee? And why should it succeed just because it's sirolimus below the knee? I mean, I'm struggling to, from the outside, to understand that.
Valid questions. Marianne?
Could I answer the question, or would anybody else answer the question?
Anybody else want to take that?
Eric is laughing, so maybe he can.
Go on, Eric.
I mean, it's a great question. I think obviously the paclitaxel controversy propelled this conversation forward. There were companies working on limus platforms before paclitaxel controversy, but a lot of companies, including strategics that make the paclitaxel devices, saw the threat to the market and definitely at least examined or pivoted towards the limus platform. And I think what people do anchor on is almost everything in the coronary space is limus up until recently. All our stents that are available in the US are all limus.
Yeah, everolimus. Yeah.
Exactly, everolimus or sirolimus or zodolimus. And so we just got our first drug-coated balloon in the United States, and it's a coronary drug-coated balloon. It's a paclitaxel balloon, funny enough. And so I think the challenges right now are we don't know what's the right drug for below the knee. And there's a little bit of a fishing exhibition here of trying to find the right agent to match that disease state and whether limus is it or not. I think one thing that does stand out, though, is the distal embolization issue that has occurred with paclitaxel devices seems to be non-relevant in the limus balloons that have much less distal particulate and issues. And so if we're ever going to think of some ways that device platform can favor the below the knee space where others have created challenges, I think that would be one. And Thomas, knows this better than anyone, having led the IMPACT Deep trial before. But I don't know, Thomas, what you think about that concept. But that's one strength of the limus balloons for sure.
Yeah. Well, initially, the hope was that paclitaxel is efficient in all vascular beds, and IMPACT Deep was the first study to show that there is something wrong with paclitaxel. Not knowing what was the reason for the lack of biological efficacy, and therefore the idea was, is paclitaxel probably not the right drug for below the knee based on former drug-eluting coronary stent studies below the knee. Texas, as a drug-coated paclitaxel releasing DES, was not very efficient below the knee. However, the limus-coated drug-eluting stents have shown really excellent outcomes. And this was basically the reason why a lot of companies did jump on the idea to develop a specific limus-coated DCB, in particular for BTK indication. And after this ugly safety discussion regarding paclitaxel, obviously the same companies decided also to evaluate the performance of those limus DCB above the knee. So that's basically how it started, the development of these limus-coated DCB developments. Yeah.
So we're currently in the space of seeing whether the limus DCBs truly work below the knee.
May I ask a question to Brian?
Yeah, please do.
Yeah. You had been the PI of this first in-man study with this, if I remember correctly, it was a crystalline-coated limus DCB for BTK disease. And after the presentation of these really amazing one-year outcomes, I've never heard anything new from this device in particular. Is there anything on the horizon?
I'm not sure that, I think you might have been thinking of a different trial. I'm not sure what device you're talking about.
The Surmodics device for below the knee.
Oh, yeah.
The sun
And then-
lens.
Yeah, sorry, I wasn't part of that, in fact.
Okay.
But what I will say is I think that the question, I think the question really highlights that this is an open debate about whether or not limus is really the right drug. But I think what I would say is I would reiterate what Eric said. The paclitaxel issue really drove this question forward. There are signs that maybe paclitaxel, as you just said, Professor Zeller, that maybe that's not the right drug or not the right device drug combo. And what is very clear is that limus does have some potential properties, anti-inflammatory properties, et cetera, that maybe give a little bit more reason for us to be optimistic about getting a device approved for the below knee space. Certainly, we've also learned a lot from our prior below knee trials that I think are applicable to the new stent trials as well as the DCB trials. So I think there's a lot of reason for optimism, despite the fact that none of us have a crystal ball to tell us whether or not limus is going to be the right drug necessarily.
I'll tell you though, the fun debate, and we'll have this at Charing Cross because I know Sirona update will be presented as above the knee, and I don't know if limus is gonna upset paclitaxel above the knee and what role limus might have, even if it's not inferior to paclitaxel. So I think that will be a really nice conversation to have on stage. And again, Sirona was a trial looking at paclitaxel versus sirolimus DCB above the knee and showed non-inferiority at 1 year. But is that enough? What else do we need to change that space? Might be a very different conversation than below the knee, which we know has other unique challenges.
Thanks, Eric. A lot going on. And just want to bring Naz in here because I've sort of ignored him so far. Any thoughts on limus or other DCBs below the knee from your position?
Thanks for bringing me in. I guess I can't really add very much more than what the experts have said. My main area of expertise is sort of surgery in the lower limbs. So I'm not going to add anything additional to what the experts that have already spoken on this topic.
Thanks, Naz. I think any final thoughts from you, Marianne? Because we sort of cut in and do you have any?
I think everything has been said, and especially as has been summarized. For me, it's mainly in the below the knee space. I have some doubts about the above the knee space, and below the knee also see this big advantage of not this kind of distal.
I think moving on. Thanks, Marianne. We'll move to Thomas. Move from the limus below the knee to vessel prep. So is it necessary? Which are necessary? Over to you, Thomas.
Well, the previous topic is a very good introduction into the question whether vessel preparation is relevant or not. We have heard about some failed trials below the knee and also above the knee with particular DCB brands. And it's not yet fully understood what is the reason for that some devices are effective, others are not. And one idea is that it may be a mechanical background of failure, and this is very prevalent in particular below the knee, where we have much more prevalence in severe calcification as compared to above the knee. So the potential failure mode, in particular below the knee of drug-coated balloons, may be a lack of biological efficacy, but on the other hand, it may be a mechanical issue, meaning recoil, mainly induced by calcification, and therefore a lot of different approaches are under development or already introduced into the market for vessel preparation. These are, for example, specialty balloons. The first one was the cutting balloon. In the meantime, we have the Serenator, which is a cutting balloon-like device with a better profile. We have devices for calcium modulation, meaning lithotripsy. We have one device which is already on the market, which is based on acoustic shock waves. Another one based on laser induced shock waves, just finished enrollment. The data will be presented this year. And the other way is simply to remove the plaque, meaning using different kinds of atherectomy devices. And in particular, in the below the knee space, there had been published 2 randomized controlled, more or less pilot studies, because they had been underpowered, unfortunately. One did evaluate directional atherectomy as adjunct to DCB, and the other one orbital atherectomy as adjunct to DCB, compared to no atherectomy, so DCB only. And both of those trials have shown the same trends in order to reduce restenosis and reduce TLR rates, but due to the small number of the patients enrolled in both trials, these differences had not been significant. So what I would like to say with regard to the current evidence we do have is basically for below the knee, there is no study yet that has shown any benefit, because there is no randomized comparison. There are potential devices like the Spur system, which is a non-permanent stent device, a non-permanent scaffold device, which has shown to reduce recoil. But as mentioned, it's early results we do have. It's single arm mainly, and the vessel preparation has to show its value in larger randomized controlled trials. Worth to mention, we have one trial for shockwave lithotripsy above the knee that has shown to reduce the number of bailout stents needed. But regarding patency, there was no real benefit up to 2 years as compared to a plain balloon angioplasty for vessel preparation.
Thanks. So what do we need, Thomas, to actually move the vessel prep argument forward? If you had the endless money and the world at your disposal, what would you do?
Well, basically, first of all, I don't believe that vessel preparation as a standalone therapy will solve our problem of durability of our peripheral interventions. It has to be in conjunction with something else, whether with DCB, following the leaving nothing behind concept, or improving the environment for stent implantation, for better stent expansion, and with this also improving stent patency. And we need definitely these trials showing that vessel preparation does improve the outcome of the, I would name it the definite treatment, meaning DCB or stenting or whatever kind of treatment. This is what is definitely needed, because these vessel preparation devices usually are very expensive, except a couple of or a few specialty balloons, but even those are more expensive than regular balloons.
Thanks, Thomas. I'm going to bring Naz in here because he works in the same economically challenged health system that I do. Do you use vessel prep in your practice?
Not a huge amount is the honest answer to that. I generally rely on my sort of interventional radiology colleagues, and some of them started using IVUS and things like that, and the atherectomy devices as well. But me personally, I generally stick to surgery just to the volume of work that we have up in Manchester.
Thanks. Marianne, do you use vessel prep? I expect you do.
Yeah, we use vessel prep, all kinds of vessel prep, with regard to how to say financial reasons, we mainly use specialty balloons because they are much cheaper than other kind of vessel prep tools. But we use vessel prep tools also according to what kind of lesions we see, calcified lesions, long lesions, CTOs or whatever. So we really address our vessel prep tools to what we see. But I want to step into what Thomas said. The point is we need to see that vessel prep is really helping us, or what kind of vessel prep is really helping us to improve the final outcome. And that's the most important thing. And this needs to be shown.
Well, it sounds like all of you are calling for more evidence. And if anything, the Charing Cross certainly wants to focus on evidence, not just innovation for the sake of innovation. What should we be looking out for when it comes to collecting the evidence to do precisely what you've set out? What trials are there currently in play? Or do you and your colleagues have to start those trials?
Who's that to?
Well, the panel. To you, Rob, to start with, because you do vessel prep, but what's the...
Well, we do, but we are constrained by the cost of the devices in the UK, so that's a big thing. We're reliant on congresses like the Charing Cross to hear the latest evidence, so that's why we're interested to hear.
But what data is out there at the moment or in play that we're seeking to get the results? I know there's a Sirona trial, that's limas versus paclitaxel, but are they using vessel prep, given what Marianne said about it's useful potentially for preparing for good outcomes? Or with drug resorbable stents, are you using vessel prep in the trials that Eric and Brian are doing?
Yeah.
I don't know.
I'll jump in and comment a little bit about each of those. In the light PTK trial, we did not allow vessel prep, and there was a requirement that the pre-dilatation balloon had to be fully expanded before we'd implant a device. And if that did not happen, the patients would be deregistered. And we were pretty concerned that we would have a lot of deregistrations for that reason. But in fact, at least in the patient population we had, which were admittedly somewhat short lesions, we really did not face that. We didn't see a true need for vessel prep. So I'm not saying that vessel prep is not important for scaffolds, because I think it probably is. It can probably be advantageous, but we haven't seen it to be a clear need. Now, I think that's different in the above knee space, where atherectomy, especially excisional atherectomy, which I use quite a bit in the US, those patients or those lesions are subject to a high rate of restenosis before we had DCBs. And so really pairing DCBs with atherectomy is a way of debulking the lesion and then preventing that restenotic process. And that was what we looked at in the reality trial, of course, which looked at the sort of most difficult and longest of these type of lesions, and found pretty good results you would see with much shorter, much less complex lesions by doing that combination of drug plus vessel prep. So I think, at least for the above knee space, that combination of vessel prep device to really get a good luminal gain followed by drug to prevent restenosis is probably a winning strategy, and there is some data for that. The low knee, I think that's still uncharted territory to some degree.
Thanks, Brian. That's a good take-home message from this discussion. I think we'll have to move on, given that time is passing, and we're going to go to Naz, who's going to talk about, or going to tell us how we can save more legs from amputation. Naz.
I guess the best way to look at this question is to understand how can we save more legs in the hospital space, and also outside of hospital as well. There are two very different techniques I think we can approach for those. I think in hospital, what's really important is having multidisciplinary teams where the service offers everything that is on offer when it comes to the above knee and below knee technologies, both radiological and surgical as well. Often people will just provide services that they can actually provide, as opposed to having a team that can provide all the services and then choosing the right technology for the patient themselves. So I think having a highly functioning team that is able to offer those services is really important. But I think where the real difference is going to be made is outside of hospital. And that is about getting patients early in their disease, where you can actually make a real difference. If you look at patients, once they've got a foot ulcer, if they're diabetic, particularly if they've got peripheral arterial disease, the mortality rate is actually requires 1 to 3% per month. Often, if the patients have these ulcers, the prognosis is worse than many cancers. 10-20% at 1 year for many of these patients.
Naz, just a very quick question: is the amputation rate or the numbers increasing in the United Kingdom or not?
It's actually coming down.
And what is happening in Manchester then?
Yeah, so in Manchester, overall, over the last 6 years, over the last sort of 15 years, amputation have dropped from about 1,000 a year down to about 500. So over 15 years, it's dropped by 50%. Over the last 6 years, for the whole of Greater Manchester, just for context, Greater Manchester has a population of 3 million people. It's one of the most deprived areas of England in the northwest. And overall, amputations have dropped by about 21% within that time frame. But where we've done some particular work, it's dropped by 46% within the same population of 2.
So that's a story of success. Are there any areas where it hasn't been successful in the country, or are we dealing with a problem that's essentially been solved and everybody can look forward to far fewer amputations in the future?
So I think that's hit the nail right on the head. So, overall, the picture is good, but when you look at each variation in different parts of the country, the story is very different. So in some parts of the country, amputations are going up. In other parts, they're going down, and they're going down at different rates. And understanding where that is, it's really important. So, for example, in the north of England, amputations are generally higher than in the south of England. They're higher, about 3 times higher in men compared with women, and they're about 70% higher in the black population compared with the white population. But interestingly, in the South Asian population where I come from, they're actually 30% lower than the white population, although the cardiac intervention rate is significantly higher. So there's some evidence of perhaps the disease of atherosclerosis behaving differently. It could also be that the services are set up differently. But I think one of the big differences that can be made at a sort of strategic level is having a focus not just on diabetic amputations. Obviously, diabetic patients have a significantly higher risk of amputation, but non-diabetic amputations, people have to take that seriously as well. So we know that half of all major amputations are in people who do not have diabetes, and 30% of minor amputations are in people who do not have diabetes. The path to an amputation begins with an ulcer. And whether you're diabetic or not diabetic, the treatment is the same. You need multidisciplinary teams. You need fast access to expert assessment. You need offloading, antibiotic, good infection control, good vascular supply. If you are diabetic, you get access to these services really quite quickly. It's set up for people with diabetes. But if you do not have diabetes, you do not have access to these services. So I think that's one big difference that can be made out in the community.
Do you mind if I just try? That's really helpful, because what you're describing is that there are underserved communities. You talked about the difference between North and South, the difference between the black community versus the Asian community and the white community, rates being very different, and therefore some insights potentially in dealing with particular underserved communities to bring an overall further reduction in amputations. Brian, you're in the great United States, and we're led by the great United States. Everything that happened now seems to be around the White House. But over your side of the pond, what's happening to amputations? And is it a similar picture for you, or is it very different?
We've certainly seen a lot of excitement and a lot of chaos on our side of the pond recently. And I think that the same is true in terms of amputation prevention. I think that the issue of disparities is one that continues to be a problem. And if you look at the geography of the U.S., there are certain areas that have extremely high amputation rates compared to other areas, and largely they mirror the degree of vascular intervention that is going on in those areas, or the lack thereof. And so generally, you see a correlation between lower amputation rates in areas where there is a high penetrance of vascular intervention, diagnostic procedures, and that sort of thing. So I think that that's good evidence and proof that whether we use endovascular therapies or open therapies, a lot of amputation prevention and solving the disparities in different areas of amputation rates has to do with diagnosing early, getting appropriate workup and diagnosis done, and then providing some degree of intervention to revascularize the patients.
So I'm going to wrap this particular segment up because we've got to go to the last topic before we run out of time. But essentially, I think there's a lot of commonality then between what's happening in the United States and in the UK, and it'd be interesting to find out what's happening on the continent of Europe. Certainly, one of the things that Charing Cross will be looking at is how do we reach out to those underserved communities. There's something that we run with the Rouleau Club, that's trainee vascular surgeons, about how we can persuade communities to step forward to receive that important intervention and get the referral pathways to improve to those underserved minority communities in particular. You mentioned the Black community now as particularly at risk. We're now moving to the last question, Rob. So you're to drive, obviously, what's the evidence around bypass versus endovascular? If you're going to lose your leg, what should you have first? What should you do as a patient?
Well, Eric's going to tell us because he's going to talk about the Basel and BEST-CLI trials.
Eric.
Yeah. It's great to round off this conversation, which has been fantastic. I know we just have a few minutes, but I think this has been really the heart of Charing Cross in the past years is coming off the BEST-CLI trial in the U.S. and the Basel II trial done in the U.K. and surrounding areas. We've had a really rich conversation about what's the right primary strategy for our CLTI patients. And, I think this conversation is ongoing. There's no one perfect solution for every patient is the take home. There's not one specialty for every patient. I think is the other take home. And developing algorithms and team-based approaches, as Naz mentioned, for amputation care is just as important for revascularization strategies. And so I think there's a lot of great conversation to have. There's been newer data that have come out of both trial programs, but most relevantly in the U.S., and I made a comment about this on stage at Charing Cross last year, is only about a third of our counties in the U.S., our segments of the U.S. population, about a third of them have even access to a vascular surgeon. And so that means only a third of them have access to a bypass surgery if they qualify. And so, I think we as the conversations evolve and the data evolves, we also have to think about the practicality of what we can do for our patients. And even if some people feel bypass is the best option, but it's not available, then we need to think about what's the best available option that's, for our CLTI population in particular.
Can I ask you a question that people wonder about all the time? Why did you get different results from the BEST-CLI and the Basel trials? Why were they different?
Look, I think that's a great question that will be well vetted at the Charing Cross meeting. And there's a lot of nuances. And just to remind everyone, there are differences in terms of the vessels treated, Basel II being primarily below the knee, BEST-CLI involving above the knee lesions as well. There were different operators, primarily vascular surgeons in the US trials doing both arms, primarily interventional radiologists doing the endo and vascular surgeons doing the surgical arms in the UK trial. And then there are different endpoints. We included repeat intervention or target vessel intervention as part of the BEST-CLI trial, and that was not part of the amputation-free survival endpoint for Basel II. So a lot of nuances there. I'm looking forward to diving in with everyone. There are reasons why these are different. There are also a lot of similarities that help us get a more holistic picture. And again, I'll just focus on the fact that there's no one right strategy for any patient or any lesion type. And really, this requires a close eye and a multidisciplinary approach. And hopefully that's where the whole field moves as these data evolve.
Thanks. We're actually 1 minute to 4, so I think we're more or less out of time. The time has passed really quickly for me. I hope it has for you all. We've heard from some great leaders in the vascular field. We heard about the bioresorbable stent trials and how exciting that field is. Limus trials, which one will be best in the BTK and will they actually be better than plain angioplasty? Vessel prep, we heard there's lots of tools and we're looking at which are best and for which patients. We know we need to save more lives from amputation and the problems are the same each side of the Atlantic Ocean. And finally, there are some great trials out there going on and the answers are not all in on the BEST-CLI and Basel trials. Will it give Stephen the final word?
Yeah, well, I'd say, Charing Cross that's taking place at the end of April is all about controversies. And it sounds like there are lots of controversies in the peripheral arterial disease area. We've been challenging the evidence today, and I'm not sure, but we've got broad consensus, I think, on a lot of topics. And that's, after all, what we want to see as a vascular community. But this is the first of a series of Vascular News live broadcasts. And next week, we continue with the aorta. It's been great to have you all, a fantastic panel of experts. And see you all again next week for the focus on the aorta and also vascular access.
Bye, everybody.
Bye, everyone. Thank you.
Bye.
Bye-bye.